afternoon. Welcome to the Spring Symposium of the Urban Health Institute. I can think of no one more fitting than Sir Michael Marmot to be giving this talk. The gap between the residents who live 5 blocks from here and those who live 15 miles from here is a life expectancy of about 10 years differential. If there ever were a place where the divide in this social and health inequalities of our population is underscored, we see it day in and day out in our neighborhood and in our community. What makes Professor Marmot's work so both important and powerful is that it shows clearly what exists and points clear directions at what can be done. And while his work has been predominantly in England and Great Britain, and recently globally, I would suggest there are extremely powerful messages for our neighborhood as well. Michael Marmot was born in London, grew up in Sydney, went to medical school at the University of Sydney, went to Berkeley for his MPH and PhD degrees, and then went to University College of London, UCL, as professor of epidemiology, chair of the department, and has spent the last 30 years addressing issues of health inequality. He is best known for his research work and landmark research work in the Whitehall studies, Whitehall 1 and 2, that showed very powerfully the steep gradient between employment and class and health status along a wide range of outcomes. More recently, he has chaired the WHO Commission on Health Inequalities, and will be speaking on some of those global issues with us here today. Prime Minister Gordon Brown asked Michael to chair a commission on health inequalities in Britain 2 years ago, and that report was issued just about 6 weeks ago, 2 months ago now. That has already had a wide and rippling effect throughout Great Britain. I think it points strongly to how data can help frame the debate and the discussion. And so for us, it is a tremendous pleasure, and we're very honored, Michael, that you have joined us today. Please welcome Sir Michael Marmot.
I said when I began a noon seminar, it was a great pleasure to be here. That pleasure's diminishing by the hour as I've been talking non-stop since about 10:30 this morning. But it's a moderate pleasure to be here. If I can figure out how to go forward. Because this was sponsored by Urban Health, I am going to talk about the work of the Commission on Social Determinants of Health, but orient it somewhat to urban health. Were this being sponsored by Child Health, I would orient it to Child Health, because indeed we covered the spectrum of important determinants of health. The starting point for the Global Commission on Social Determinants of Health, set up by the World Health Organization, were these sort of figures, with which I think you're familiar. This is life expectancy for men, benchmarks. Life expectancy for men in selected countries: Iceland, 80, Sierra Leone, about 38. If I looked at women, life expectancy in Japan for women is 86. In Zimbabwe, it's 32. Chairing the Commission on Social Determinants of Health has taken me into some very odd locations, none odder than Goldman Sachs. I went to a meeting of threats to global markets, and I was asked to talk about health. And I showed them figures like this, and I said, there's no good biological reason why there should be a 50-year difference in life expectancy across the world. You did it. So I'm sitting there, I'm standing there talking to this group of bankers, and the chair said to me, they look stunned. And indeed they did. I said, these differences arise because of our global social and economic arrangements. There is no good biological reason why there should be a 50-year spread in life expectancy. When we published our report, I pointed out that health inequalities of this magnitude, as Bob said in his introduction, is not just a problem for them in poor countries, but for us right at home. The Scottish city of Glasgow, men in the poorest part of Glasgow have life expectancy of 54, 11 kilometres away. A kilometre is a measure of distance. Just checking that you... 11 kilometres away, life expectancy in the richest part of Glasgow is 82. A 28-year difference in life expectancy in one Scottish city. Men in the poorest part of Glasgow have life expectancy that's 8 years shorter than the average in India, which is 62. 3/4 of the population of India lives on $2 a day or less. No one in Glasgow lives on $2 a day or less. You turn on the tap, the water's safe to drink. The food's safe to eat. Well, in the short term, it's safe to eat. Deep-fried Mars bars can do you in the long term. But in Glasgow, the poor die of heart disease and cancer and alcohol-related deaths. They don't die of diarrheal disease. So powerful is the operation of the social determinants. I was at Goldman Sachs and I was talking to the bankers and then, do I have to do it all again? Just let me know where I can start from. So powerful is the operation of these social determinants of health that we can have these huge differences within one Scottish city. So health inequalities is a problem for all of us, them and us. And if we look what's been happening, there are patches in the world where health inequalities have been growing by region. So we see here in sub-Saharan Africa, life expectancy at birth has actually been dropping. And if we go back, let's say, if we look at Asia and sub-Saharan Africa, we might have thought that improvement in life expectancy would be equally different in those places. And yet what happened was Asia got very much better rather rapidly, and sub-Saharan Africa improved for a while and then got worse. And if we look at that with some sample countries, Costa Rica's always been interesting because it's one of those countries of relatively low income that has good health and kept improving. Vietnam and Zambia improved at about the same rate. This is one of the better successes of US foreign policy, and Vietnam is nearly up to the Costa Rican level, and Zambia went down. So we can get these changes very quickly, and we can see growing inequalities. One of my points is that it's not just a matter of health in the poorest of the poor, but everywhere we look, health follows a social gradient. This is under 5 mortality per 1,000 live births, and it's a graded phenomenon in country after country. And the point that I made with my English review that I talked about in the seminar at noon was that the implication of the gradient in health is that we mustn't focus only on the poorest of the poor. The implication of the gradient is that we need to deal with the whole of society. Now, most of us in health, and certainly the default position of British social policy, is let's focus on the poorest of the poor. Surely that's what demands our attention. I would argue that the gradient suggests we're all at risk. I was trying to make that case once in Her Majesty's Treasury, and they were talking about, in fact it was when they were starting Sure Start, and they were talking about focusing on the very worst. And I showed them the data. Look, education, literacy levels follow the gradient. And one senior civil servant said, "Oh, don't come to us with that Scandinavian nonsense. We're Anglo-Saxons." He was actually Irish-Jewish, but that's by the by. We're Anglo-Saxons, he said. We focus on the worst off. That's our policy. Well, it seems to me the gradient demands that you pay attention to the whole of society. I said to the people who came at lunchtime that I was going to talk about different things this afternoon, but you will recognize this graph. But I show it again because it makes the point of how important the gradient is within our own societies. Each dot here represents a local area, and these areas are divided by degree of income deprivation. And this is life expectancy. And you can see it's a graded phenomenon. Virtually every centile, those near the top have lower life expectancy than those at the top. It's graded. And this much steeper graph is disability-free life expectancy. You cannot think that the problem of health inequalities is simply those down there, because it's a graded phenomenon, and we need to be taking action on the whole issue. Of course, it's only in Britain that we have class differences. You don't have them in the United States. This is life expectancy by socioeconomic deprivation in the US, male and female combined. High deprived, high affluent there, this graded phenomenon. Now look what's been happening. 1980 to 82, 1998 to 2000, life expectancy for the most deprived improved by about 1.8 years. For the most affluent, life expectancy improved 1, 2, 3, about 3.5 years. So the gradient got steeper. And that's very important. So message 1 is the gradient. Message 2 is the slope of the gradient can change over time. People are often saying to me, and I get angry. Well, actually, I'm British. I don't get very angry. I get mildly irritated. I get mildly irritated when they say, okay, we accept your argument. Social and economic inequalities in society relate to health inequalities, but don't all societies have social and economic inequalities? Therefore, doesn't it follow that we'll always have health inequalities? And my argument is yes, but the slope changes. Look how rapidly the slope changes over time, how it got quickly steeper in less than 20 years in the US. So if it can change not as a direct, deliberate effect of policy, but perhaps as an unintended consequence of social and economic changes, then perhaps we can pursue policies to make that gradient flatter. We've been working in the English city of Liverpool, not as big life expectancy differences in Glasgow, but it's a 10-year difference. And it's not just in the rich countries. Our colleagues from Brazil who are working with us in Porto Alegre, looking at cardiovascular deaths of people aged 45 to 64 by the socioeconomic level of districts: high, medium, low, low. And he's looked at attributable CVD deaths by saying everybody who's below the highest have their deaths attributable to being below the highest. And you can see this striking gradient. So we see it everywhere. Very important. We published the report of the Commission in August 2008, the Commission on Social Determinants of Health, and we entitled our report, "Closing the Gap in a Generation." Are we bonkers? I've just said there's a 50-year gap in life expectancy across the world, and we're talking about closing the gap in a generation. Completely bonkers. This was not a prediction. It was not a prediction that we would close the gap in a generation. It was a statement that we have in our minds the knowledge to close the gap. We have in our hands the means to close the gap. The question is, what do we have in our hearts? Do we have the will to close the gap in a generation? We were pushed to make the economic case for action on social determinants of health. Being somewhat stubborn, albeit polite, I resisted that argument, and I said that the reason we're doing what we're doing is a matter of social justice. At the Lancet lecture in London a couple of years ago, the head of the Global Fund on AIDS, tuberculosis, and malaria was speaking, and he said, we're not doing what we're doing to control these major killing diseases for humanitarian reasons. He said we're doing it for hard-headed economic reasons. And Richard Horton, the editor of The Lancet, knowing my view, I was sitting resolutely on my hands. I wasn't going to say anything. And Richard Horton turned to me and said, what do you think about that? I said, well, you get two economists in a room, they disagree. What if an economist came forward and said, controlling these major economic diseases, these major killing diseases, did not improve the economy? Would you stop doing what you're doing? I doubt it. I think you are doing it for humanitarian reasons. You're just putting that other thing up as a flag. Somebody came up to me at the dinner afterwards and he said, have you seen this week's Economist newspaper? And there were two articles based on US-based economists, academic economists, that showed control of major infectious diseases post-World War II did not lead to improvement in GDP per capita. But we should still do it because it's the right thing to do. And we took the view, and that's why we use the word health equity, that health inequalities that are judged to be avoidable by reasonable means are unjust and hence inequitable. So putting them right is a matter of social justice. And we put it at the center of what we were trying to achieve, empowerment. And we thought of empowerment as material. If you can't feed your children, you can't be empowered. Psychosocial, having control of your life. And political, having voice. And we said, Amartya Sen was a member of the Commission. In the tradition of Amartya Sen's views of justice, we said we wanted to create the conditions for people to take control of their lives. We had three principles of action: the conditions in which people are born, grow, live, work and age. And I invite you to remember that phrase because I'll come back to it at the end. The structural drivers of those conditions are global, national, and local level, and the importance of monitoring, training, and research. I quoted Jerry Morris twice today. I'm going to quote him again because he's on my mind. A great leader in epidemiology and social medicine in Britain who died last year, aged 99. And he rang me at home one Saturday afternoon after we published the Commission report, and he said, "Michael, your report has," I can't get his Scottish accent, "your report has transformed the debate." And I thought, did we quote him? And I had the report on my desk, and I said, quickly flipping through, "We quoted you on page 90. And on page 79, he said. I thought, he was 98 years old at the time. The first thing he does is get the report and say, "Did they quote me?" Yeah, right. It's wonderful. I love it. And the third was the importance of monitoring, training, and research. And putting flesh on those bones in the conditions of daily life. We talk about early child development and education, healthy places, fair employment, social protection, universal health care, and in the broader structural drivers, health equity in all policies, good global governance, gender equity, political empowerment, market responsibility, and fair financing. We said that you very much have to put in that broader context actions on public health. And we used the phrase, the causes of the causes. We know about the causes of ill health. We need to look at the causes of the causes. I was in Norway last year, and the Minister of Foreign Affairs, the equivalent to your Secretary of State, the Minister of Foreign Affairs said, "I am a health minister. The decisions I take influence health." He said, every minister is a health minister. Every member of the cabinet takes decisions that have impact on health. And I would say every sector is a health sector. Now, this is not health hegemony. This is not the doctors taking over. But it is a recognition that the key drivers lie outside the health sector. Whatever the outcome of your miserable discussion about healthcare reform, whatever the outcome of that, and I hope it's a good outcome, although I'm probably not much more optimistic than most of you, that isn't going to solve the problem of health inequalities, because the key drivers of health inequalities lie outside the healthcare system. And it's our responsibility as people who work within the health system to work with those who have their hands on the levers that influence health. I talked about empowerment. I'm an embarras de richesse here. I've got too many buttons to press. There we are. Empowerment in action. These are data from Canada, from British Columbia. And they classified communities on these factors: self-government, participation in land claim, community control of health services, education, cultural facilities, and police and fire services. Something's happened to the label, but this is the number of these cultural factors that were present. And here we have youth suicide rates. The greater the degree of empowerment at the community level, in other words, the more community control there was over these, the lower the youth suicide rate. A chilling statistic. But it suggests the importance of empowerment at the community level. Let me give you a different example of empowerment. This example from India that was actually done by World Bank economists. They had children of different castes, 11-year-old children, and they did this experiment of giving them problems. In fact, they had to solve a number of mazes. And in the first set of experiments, they did not announce publicly what caste the children were. Interestingly, the performance was identical. I say interestingly because lower caste children come from more deprived backgrounds, and one might have expected, because of the deprivation of the background, they might have performed differently. But the lower caste children performed equally well with the upper caste children. Then, in a separate group of experiments, they drew attention publicly to the children's caste background. So the lower caste children now knew that the experimenter knew what caste they were, and the other children knew what caste they were. And under those conditions, the lower caste children did worse. And they did another whole series of experiments that I won't go into here. But the interpretation was that the children of lower caste clearly had the same ability. Once it was announced what caste they were, and that they were aware that everybody knew what caste they were, they knew the system was rigged against them, because you got rewards for solving puzzles. And they knew no matter how well I work, it ain't going to work because the system's rigged against me. Now that's empowerment in action. That's depriving people of the power to control their own lives. Because it was probably quite an accurate perception on the part of those lower caste children. Does this have any resonance with people of East Baltimore? Perhaps it does. My nightmare was we would do all this work with the Commission on Social Determinants of Health, and the fate of the Commission's report would be like the fate of most Commission reports. Probably 95% of Commission reports. It arrives on your desk, then as they pile up, you put it on the floor because you don't want to file it away. You think, I must read this sometime, and you finally gets onto the shelf. And that's what the politicians and the policymakers do, and nobody ever acts. I would say that I'm not quite sleeping well, but I'm not having nightmares. The reaction to the Commission's report has been more positive than I dared hope. Brazil set up its own Commission on Social Determinants of Health as a sort of daughter of the Global Commission. President Lula holding the report of the Global Commission with the Minister of Health and the Governor of the state and the chair of the Commission. I had the honor to present the Commission's report to Manmohan Singh, the Indian Prime Minister, and Dr. Singh said, "What would you like me to do?" He's the Prime Minister of 1 billion people, and he's asking me what he should do? I had rehearsed the answer to that comment. And I said that we were doing a review in England. I said that the Commission had a global reach. We were looking at South Asia and Sub-Saharan Africa and North Africa and Latin America and North America and Europe. It was impossible that we could have a set of recommendations that applied equally in all these different contexts. Were he minded to take the Commission's report and ask, how could that translate into the Indian context? As we were doing in Britain, as they had done in Brazil, then I think it would have an enormous impact on India and potentially other countries as they saw what India is doing. And we're still hopeful that they will do something like that. This is the President of Sri Lanka, who's just been re-elected, who declared his intention to set up a review. He then said about killing Tamils, which isn't quite what we had in mind, in social determinants of health. But they have now set up a review in Sri Lanka, and I shall go back there again in June to work with them as they take action asking, what does the Commission's report mean for Sri Lanka? And in Britain, as was mentioned in the introduction, the Prime Minister, Gordon Brown, announced that I would do this, and the Secretary of State for Health, that's our health minister, similarly announced that he wanted me to translate the Global Commission's findings into a form suitable for reduction of health inequalities in England. And we published our report on the 11th of February this year, and I invite you to look at that. There's the website, we called that report Fair Society, Healthy Lives. I thought it was time to come out of the closet. I said that in the Global Commission report, Closing the Gap in a Generation, the reason we were doing what we did was a matter of social justice. I finally decided to get even stronger about it. Create a fair society, health will improve, and health inequalities will narrow. And I would say we need to take the same approach to the global society, the global village in which we live. Create a fairer globe, and the 50-year difference in life expectancy will get less, and health will improve for everybody. With the English review, we said we wanted to create an enabling society that maximizes individual and community potential and ensures social justice and health and sustainability are at the heart of all policies. And we privileged 6 domains. I get asked commonly, is this all just about income inequalities? And my answer is, if it was only about income inequalities, we wouldn't have had 6 domains for our recommendations. Give every child the best start in life, enable all children, young people and adults to maximize their capabilities and have control over their lives, fair employment and good work, ensure healthy standard of living for all, create and develop healthy and sustainable places and communities, and strengthen the role and impact of ill health prevention. And I won't go into more detail on this, which I did at lunchtime. When we turn to the global context, I'm aware that, at least in some quarters, people have finally recognized the importance of climate change. And I would say that climate change adds urgency to taking action on social determinants of health, but so does health inequity lend urgency to taking action on climate change. We have to bring those 2 agendas together. One was a bit more optimistic halfway through last year, and halfway through last year I was invited to address Kofi Annan's Global Humanitarian Forum on climate change, and I said, get health and health equity on the agenda for Copenhagen. The health and well-being of the world's poor and disadvantaged depend on it. And we all felt so optimistic. I think we need just to take a longer view in terms of the failure of Copenhagen. We'll get there. Interestingly, for those who are concerned about such things, so-called ClimateGate, the emails that were hacked into from the University of East Anglia, there have now been 2 committees of inquiry into East Anglian science on climate change, one by the House of Commons and one by the Royal Society Scientific Committee. Both the Royal Society Committee reported this morning, and both say that the East Anglian scientists do not have a case to answer. They say they're a bit messy, as scientists commonly are, but the science is sound. So whatever you've read in the newspapers about how it was all based on manipulating data is not true. The climate change data from the University of East Anglia are sound. People, for their own political agendas, are trying to manipulate the evidence, but they can't change the evidence. The evidence is sound. There is an increase in global temperature. The overwhelming evidence suggests it's man-made, and we cannot afford to be inactive. But I would argue we have to bring these agendas together. I said I wanted to put my report of the Commission in the context of urban health. Look at increasing urbanization since the 1970s, 1975, 2005, rural areas, urban areas. We now know that this is what's been happening. Rural population, urban population, there it was. The watershed. A majority of the world's population is now urban. It is urgent that we pay attention to urban health. We look at increasing emissions. India, China, and Japan, they're different scales, by the way. That's Japan, and that's China and India. So it's not that China's emissions per capita are as high as Japan. They're different scales, but you see the dramatic increase. But how are we going to do this? It seems to me the only moral way is contraction and convergence. We can't say to China, you can't develop in the way that we did in the West. We did it, and we'll pump out carbon, but you can't. Contraction and convergence, it seems to me, is the only moral solution to this problem. And we need, as I would argue, we need to get a moral fervour in our discussion of health inequities. We need to get a moral fervour in our discussion of climate justice. I won't take you through all of this. Food system, big shifts from grain to meat. And of course, meat is much more carbon intensive than is grain. Droughts, as the vice chair of the IPCC said, who's from Kenya, that weather changes are somewhat inconvenient for people in the global north. They're life and death to people in the global south. So droughts, oil, the high price of oil are pushing up the costs of food production. So it's not just, as you know, when we had the big rise in prices, people talked about using agricultural land for biomass, for fuels. It's not only that, but the price of oil going up increases the cost of fuel production. Projected global trends in meat consumption in every region going up, with big impacts on the climate. When we look at nutrition globally, this is the prevalence of underweight children under 5 in Africa, in India. But like everything else, this has to be put in a social determinants context. Look at Kerala. Sorry, I'll get to Kerala in a moment. We've got here underweight and overweight. Mexico, prevalence of underweight, prevalence of overweight. 65, nearly 70% of Mexicans are overweight or obese. India now has more obesity and overweight than it does underweight. And in fact, we talk about the double burden of communicable and non-communicable disease. A country like India has the double burden of undernutrition and overnutrition. In Mexico, sometimes in the very same household, they'll have underweight children and overweight adolescents and adults. But in all of these countries now, we're seeing the global problem of overweight and obesity. So we're facing, as a world, undernutrition and overnutrition at the same time. All of these need to be taken into account in adaptation to climate change: health systems, sanitation, food and water security, fuel, natural disaster preparedness. If you look at what happened with the 2 earthquakes recently in Chile and Haiti, 300,000 people died in Haiti, 1,000 people died in Chile. It's going to take 30 years to rebuild Haiti's infrastructure, 4 years to build Chile's infrastructure. They both affected major urban centers. As one member of the Global Commission said, there aren't natural disasters, they're natural phenomena. Social organization turn natural phenomena into disasters. The earthquake in Chile was much less a disaster than the earthquake in Haiti because of social and economic political organization. I scarcely believe this figure, so I blame it on the American Public Health Association because they gave it to me. The poorest fifth of US families earning less than $13,000 per year pay 42% of their income to own and drive a vehicle. And my first reaction is, if you're only earning $13,000 a year, why would you pay 40% of that to own and drive a vehicle? Wake up. If there's no public transport, what alternative do you have? Hang on. I skipped over the slide. A major contributor to carbon emissions is transport, of which the automobile is a major culprit. And I say we've got to bring the health equity and the climate change agenda together. Public transport, subsidized public transport, would be a major contributor to allowing poor families to get around without having to spend 40% of their income owning a vehicle when they have no alternative because there's no public transport. And if they're spending that money on transport, they're not spending it on food or education or other things. We have to bring the health equity and the climate change agenda together. And it's not just the poorest families. This is 28 metropolitan areas in the US, housing, transport, food, and health care for all households, and then working families, not on welfare, with incomes between 20 and 50,000. The relatively poor families spend a higher proportion on transport, 50% more of their income on food and on health care. In a way, these are measures of relative poverty, how much you spend on transport and food. But if the community got involved, if the state got involved in subsidizing public transport, it would be good for the climate change agenda and it would be good for the health equity agenda. Co-benefits of exercise, 60 minutes per day of biking or walking instead of using a car would improve health and reduce oil consumption and CO2 emissions. And some bright sparkers translated this into billions of oil barrels by exercise equivalent imported and domestic production. I won't go through it, but cycling, walking, and total consumption. That by cycling and walking, we could save the consumption of billions of oil barrels per day. Cycling and walking are also forms of transport, but we have to get urban design right to make cycling and walking possible forms of transport. Energy-dense foods are cheaper in the US. This is energy density, this is energy cost per 1,000 kilocalories, and you can see that the more dense the food, the lower the cost. Lard, mayonnaise, olive oil, margarine, sugar, raspberries, lettuce, broccoli. I can hear the kids going, "Ooh, hate it," salmon, etc. So we've made energy-dense foods cheap, and then we say, what a terrible problem. We've got an obesity problem, and it's poor people who are getting obese. Surprise, surprise. Let me show you this example of bringing the agendas together. Data from England. People here are classified in two ways. This is death from circulatory disease. By exposure to green space and by income. So look first at the group with least exposure to green space. 1 is the relative mortality from circulatory disease in the high-income group. You see the gradient. The second income group has a relative mortality of about 1.3. The third income group is about 1.7, and the bottom income group is 2.2. Now look at the group that has middle level exposure to green space. The gradient, but the bottom group is now about 2. Now look at the group that has the most exposure to green space. The gradient is 1.5. Now we know that exposure to green space is much more frequent if you're high income, because you live in areas that got nice exposure to green space. So that's the first disparity. But then, if there is exposure to green space, it reduces the social gradient in health. That might be an exercise phenomenon. It might be a social cohesion phenomenon. You get out and play with your friends and meet and so on. It might be something about getting out of the horrible concrete environments and seeing a bit of nature might be good. But it's an example of bringing the agendas together. We put in the English report that the recent expenditure on road improvement, had it been diverted, could have led to 1,000 new urban parks, 2 in every local district, with improvement in health inequalities and a contribution to the climate change agenda. A colleague from Brazil that I quoted earlier has been looking at segregation in Porto Alegre in Rio Grande do Sul. I'm not sure how well this shows you, but this is a high-income area. They've got nice artificial lakes, houses beautifully spread around the lake, and they'd really rather the poor people didn't mess up this nice environment. So they built a big wall to separate the favela on this side from the nice urban dwellings on that side. Just keep the poor people out. Separate communities, by golly. So if we look at income and death rate, there tends to be segregation, both of income, low income, high death rate. It tends to be the same areas. It's not perfect, but he's doing work now on looking at residential segregation and showing the more segregated, the more benefit to the rich and the more disbenefit to the poor. So segregation benefits the rich and is disbenefit to the poor. And I said in our post-lunch discussion this afternoon, inequality damages social cohesion. Inequality is not some little epiphenomenon, nor is it the motor that drives the economy. Inequality is a major damage to social cohesion. In Porto Alegre, they build walls to separate the poor from the rich. You have conceptual walls in Baltimore rather than physical walls, but I'm willing to hazard a guess that the segregation in effect is rather similar. And that means that the rich don't have a stake in what happens in the poor area unless it's a bit inconvenient. They have to travel through those areas. Because inequality erodes social cohesion. You inhabit different universes. And what happens to those poor people is a bit like what happens to the snow leopard. You sort of feel it, would be quite nice that the snow leopard were preserved, and you're willing to donate a few dollars to the charity that wants to preserve snow leopards, but you don't feel it any more keenly than that. But if you're all part of one cohesive whole, you do feel it keenly. You actually feel a responsibility if people are suffering in your society. And the greater the degree of inequality, the less likely is that to happen. But we can do things. We can do things. I said with some frustration when I was at Stanford not long ago, and people saying it's all too difficult and the problems, it's too great, and the politics, and how can we ever get anywhere? Well, you think it's bad in Palo Alto. Try the Indian state of Gujarat, where they've got a fascist government that stood idly by at the best, or collaborated at the worst, in Hindu massacre of Muslims. So they're dealing with state fascism. And the Self-Employed Women's Association of India, and Mirai Chatterjee, who's one of the leaders of the Self-Employed Women's Association, was a member of my commission on social determinants of health. And they are a trade union. They represent trade union. God, dirty word. I feel like I'm in Groucho Marx television show. You say the trade union. You remember quaint those institutions that represent the rights of workers? Because all major social advances come from collective action. Whether it's the women's movement, the civil rights movement, universal suffrage, all come from collective action. And this is collective action. Self-employed women in India are the poorest, most marginal women in India. In every possible way. Low income, slum housing, every possible way. And I won't go into the whole of Seva, but one thing they did was, as part of empowering communities, try to improve housing conditions. But rather than come in from the outside and say, we're an agency and we want to improve your housing, they said to the women, what do you want? And the women said, we'd quite like somewhere to cook. And we'd quite like a bathroom. But we do not want to be moved. We don't want to be moved into some concrete housing somewhere else. We like it where we are. So in fact, improving the housing was part of community development. They negotiated loans. It cost $500 per household to upgrade the housing. You can imagine if you got some development agency doing this, it would cost $500,000 per household, and the money would all go to corporations in Atlanta or somewhere. But the women got involved themselves. They had to contribute $50 per household of their own money, which is a fortune for these marginal women. And following the investment in these slums, there was improvement in health, decline in waterborne diseases, children started going to school, women were able to take paid work, not having to stand in long lines to collect water. That's what it looked like before the upgrading, and that's what it looked like after the upgrading. We put in the Commission's report that 1 billion people in the world live in slums, and that it would cost $100 billion to upgrade the world's slums. And I thought, I can't let that go. People will be a laughing stock. Who's going to find $100 billion for anything? When I last looked, we'd found $9 trillion to bail out the banks. For 1/90th of the money that we found to bail out the banks, every urban dweller in the world could have clean running water. Do we have the knowledge? We have the knowledge. Do we have the means? We have the means. Do we have the will? Empowerment at work is important. The Commission said that good work includes financial security, social protection, paid holidays, social status, personal development, social relations, self-esteem, and protection from physical and psychosocial hazards. This is vulnerable employment as a share of total employment. Now, when the economic downturn came, and we worried, those poor bankers losing jobs, being attacked by governments who want to do something about their bonuses, The economic downturn, yes, caused misery and hardship in your country as it did in mine. But it's a matter of life and death to people in vulnerable employment. And of course, it doesn't lead to an increase in unemployment in sub-Saharan Africa because they have no unemployment statistics. You can't turn up and get your benefits. People have to work. They'll do anything to get a few rupees or a few dollars or a few shillings to feed their children. So the global economic crisis, which we engineered, leads to passing misery in our countries and life and death and intolerable worsening of conditions in poor countries. We were talking about this at lunchtime, the family planning agenda. We can have debates about whether this contraception or that means of contraception, or whether you're allowed to push contraception at all. Does it contravene somebody's religious beliefs in God knows where? The issue is empower women, and you don't have to think about the family planning agenda nearly to the same extent. In country after country, no education, secondary education, and this is births per woman. Empower women, and all sorts of problems improve. Empowerment has to be at the center of our global health agenda. BRAC in Bangladesh, microfinance. In Bangladesh, almost 90% of girls are married before 18 in some regions. Microfinance program for girls in 2004. 3 years later, 40,000 adolescent girls had gained confidence, skills and capital to run their own businesses and manage their own resources and take control of their own reproduction, get married at a later age, have fewer children. I said to colleagues at lunchtime when we were talking about the English review that the response I had from the community in the English city of Liverpool, from community groups, was along these lines. They said to me, we don't want outside experts coming and telling us what we should be aiming for. Our values should shape our goals. That's what community empowerment means. Deciding what your values are and having our values shape our goals. They said it's the nature of society that's the issue, not just the quality of programs and services. The measurements should reflect what we want to achieve, and the journey is important as well as the destination, the importance of local ownership. I said I wanted to invite you to remember this phrase. I was invited to address the Economic and Social Council of the United Nations, the high-level segment, which was held in July in Geneva last year. That was nice. But what was thrilling to me was that Ban Ki-moon, the Secretary General, in his opening address to ECOSOC, said this: inequities in health outcomes persist within and among countries. Most of the difference is attributable to the conditions in which people are born, grow, live, work, and age. I was chairing a session of ECOSOC the next day, and I said to the president of ECOSOC, do you think Ban Ki-moon, the Secretary General, knew he was quoting from the Commission report when he said that phrase? And she said, that phrase is out there. I'm hearing it from all over. So at least it's being taken up. I had the humility to go back to my family. I was having dinner at home. Occasionally I get there, having dinner at home, and I said, I wonder if one single person in the world has had their health improved because it's on the ECOSOC agenda. And my then 17-year-old daughter said, Daddy, even a baby step is a step. So perhaps we've taken a baby step. in the direction of getting equity on the agenda. Turning my nightmare into a dream, my dream would be a world where social justice is taken seriously. Thank you.
Thank you very much. To reflect on Professor Marmot's presentation, we're very fortunate to have two colleagues. Martha Hill is the Dean of the School of Nursing. She graduated here from Johns Hopkins School of Nursing, went to the University of Pennsylvania, returned to the Bloomberg School for her doctorate, and has been at the School of Nursing since about 1985. She really has built her entire career working in East Baltimore. Her research is focused on hypertension, and particularly hypertension among African American males. Because of her work, she has been named to, became the president of the American Heart Association, named to the National Academies of Science, Institute of Medicine, where she serves on the Executive Council. I'm not sure that's the right name of it, but the Executive Council of the IOM. She co-chaired a study entitled Unequal Treatment about a decade ago or so. And the issues that we're talking about have clearly informed and been the cornerstone of her entire professional career. Dean Emeritus Al Sommer graduated from Harvard, came here, did his, in medicine, came here and did his master's degree in epidemiology, is an ophthalmologist, professor in ophthalmology, and subsequently in 1992 became Dean of the Bloomberg School of Public Health. Most all of you are well familiar. Al's career has been marked by numerous extraordinary things, but his cornerstone research contributions globally have been in the area of vitamin A. That research and the intervention research that followed it is attributed with saving millions of people's visions and perhaps an equal number of young children's lives as we've come to both understand that vitamin A deficiency predisposes infants to a wide range of causes of mortality and as well as morbidity and blindness. Because of that work, Al was named to the Institute of Medicine as the recipient of the Albert Lasker Award, which is the most esteemed award that the United States gives in science, and is as familiar as anyone in this community with the issues that we face. So thank you all for joining us. I'd invite you to the table, but perhaps before that, I would ask Martha to lead off with some comments, then Al, and then we will open it for discussion. Do you want to speak from up here? Sure. There's room.
Well, thank you, Bob, and thank you very much, Dr. Marmot, and good afternoon to all of you. Yes, you're correct. I have devoted most of my professional career to looking at social determinants of health and asking the question, what do nurses do and what difference does it make? And it led me from an initial fascination with intensive care units, which wasn't long-lasting, because I don't have a degree in biomedical engineering, and I found it very frustrating to have to calibrate machines first before you could assess the patient accurately. And then it was very difficult for me not to be able to have a social interaction with the patients and their families where you could really, where I felt competent to be able to help them in times of such urgent crisis. And I gravitated to public health nursing, where it was much lower tech and much higher interaction with people in a way that the challenges of helping people in the context of their daily lives became very, very challenging and rewarding for me. My interest in high blood pressure care and control came because, as a nursing student, I had the opportunity to take care of several patients who had had massive strokes due to uncontrolled high blood pressure. This was back in the days when there was something we called malignant hypertension. And systolic blood pressures of 200, 240, 250 were what brought patients to the emergency room in severe distress and comas, and often, typically, death. And at that time, with the increase in effective pharmacologic agents, it became a matter of both individual, provider, and social needs to make sure that these medications were getting to the people who needed them and where we could prevent the fatal strokes, the incapacitating strokes, heart failure, and renal failure. And that whole notion of prevention and of applying research findings into practice in a community became, for me, what was, if you will, the calling. And that was where I wanted to focus and do my work. One study led to another, but the call to come back here to what I know as hygiene was irresistible. And my great challenge was to decide what department to apply to get my PhD. And many discussions. The training grants then were in mental health. That was attractive. The work that Sam Shapiro was doing in health services research was very attractive. The coursework in epidemiology was important to learn and understand. But where I ended up was in the Department of Health Behavior, because I was very, very interested in health education. I was very interested in the social determinants of health, and in looking at what we could do within organizations that delivered care, and how we could train providers, and how we could work with individual patients. I wanted to understand more about that, and I wanted to be able to try to increase not only our understanding, but the effectiveness of what we knew. The two greatest opportunities I have had in work, one was the Iom Report that Bob referred to. That was in 2002 that it was published. I got a call one day in my office saying, from a senior staff person at the IOM saying, "I've read all your work. I want to talk to you. Would you come down and meet with us?" And they were very interested in the work that we had done at that point. It was with my colleagues David Levine and Lee Bone, both of whom are deeply rooted in this school. Work that we had done in West Baltimore as well as East Baltimore, looking at factors that influence high blood pressure care and control. And these were a series of studies. David and Lee did one in the emergency room, looking at factors that influence people who arrived there with uncontrolled blood pressures, and then following what happened to them after they were discharged from the emergency room. Studies we'd done in West Baltimore with a household survey going door to door, and looking at literally where people lived, and then understanding whether or not they had had their high blood pressure diagnosed, treated, and effectively controlled over time. And then the initial work that I'd done in the area of working with young black males with high blood pressure. I had learned that if you want to come to Hopkins and you want to get on the research tenure track and you want to be successful, you need to find a problem, a gap, about which you are passionately interested, in which there hopefully is a lot of people who have this problem, because these rare conditions are rare, and that makes getting your sample more difficult, where there are actually you're not the only person who cares about this problem, and if you're lucky, it's a problem that has really economic consequences, so that the investment in new interventions and new ways of delivering care and taking care of people will bring an economic return as well as a health return to those patients and their families. So my interest in high blood pressure care and control, and looking at the national data, what we saw was that young black males were the group, the age, sex, race group, that had the poorest rates of diagnosis, the poorest rates of treatment, and the lowest rates of control. And they had the highest rates of complications because of the fact that they were so poorly diagnosed, treated, and controlled. And I thought, this is it. This is the path. This is the way. Because from my public health nursing experiences and my experience running nurse-run clinics, the group of patients where you saw the most devastating problems were in the young and were in the males. And so that became my way of saying, this is a prevalent problem. This is a serious problem. There are horrible consequences here. And there's a lot that could be done if we could just get the treatment interventions lined up. And so that led to a whole series of studies. And I well remember the first time I went down to talk to someone at NIH about getting started. And I had this grand vision about setting up nurse-run clinics, and we were going to have community health workers, and we were going to find these young men, and we were going to engage them in trustful relationships, and we were going to get these blood pressures down and keep people off dialysis and out of the stroke units. And after I described this to the project officer, the person said, "What makes you think you could do this?" Well, that was the gauntlet. That was all it took for me to say, I'm going to show you how I'm going to do this. And that was a very hard run because they made me re-demonstrate that nurses running clinics could lower blood pressure. We had to redo, and you had to do all the preliminary work. And you know, the preliminary studies had to answer the question before you got the study funded to do the big study. So it took years to work the way up the chain to eventually get the clinical trial funded. And then we were able to get funding for 12 months, and then we extended it to 36, and then we were able to extend it to 5-year follow-up of this cohort. These men, average age 41, 76% unemployed, 64% had spent at least one night in jail. The majority had multiple addictions. 64% had 2 or 3 addictions, drugs, alcohol, tobacco. Were, I will tell you, a marvelous group to work with. And within the group, there was enormous heterogeneity and great strength. We learned a lot. They taught us a great deal. Someone say, "Oh, you've got to study John Henryism. You know, they're really angry. They're really, disadvantaged. They're stressed. This is what's going on." When we evaluated John Henryism, we had very low scores and very little variation. And we continually did formative and summative evaluation as we did the study. And so we'd sit with the men that were waiting for the appointments and talk with them and ask them questions. And one question was, "Can you help us understand the results of these John Henry questions?" And one said, "Well, there's no point in getting angry and upset. There are no jobs." And I said to myself, I think that's what they call learned helplessness. And we then looked at depression. 34% of them had clinical depression that it was unpicked up. But if you don't evaluate, you don't know, and there you are. So we did a whole series of work. And to make a long story short, we followed this cohort for 5 years. We were able to get blood pressure control rates down. We found some drift at year 4 and year 5. It is really difficult to sustain these interventions because we were working with a group that many of them had no homes, many of them had no jobs, they had no skills for today's employment market, and the point that was made about transportation, they had no cars, they didn't have driver's licenses, and the jobs that they could get probably were in construction, and those were out in Lutherville or somewhere, and there's no way to get there if you don't have wheels and a motor. So we saw that helping people get a job became a very powerful determinant of whether or not they were able to get into care and stay in care. And yet no national guideline that I know about says that helping people get and keep a job is a predictor of improvement in health and achievement of outcomes. And so I applaud Professor Marmot's presentation because it is about finding people in the context of their daily lives and helping them in the context of their lives to be able to have the resources, and that's the psychological energy, as well as the pharmacy card, as well as a way of measuring their blood pressure at home so they can take control and have the closer feedback on the value of taking their medications and how that helps them control their blood pressure. I've never seen a low sodium line at a soup kitchen. I think the medicalization of a lot of these conditions and the notion that you have to cope with all the pathophysiology to get the improvements is misplaced. We really need to find what are the effective, most efficient, and economical ways of helping people control their blood pressures or any other predictor or marker that they have for poor health outcomes. And so the young black male study was the second, that's what we called it, part of my work that led to a series of publications, and pleased to tell you that I think one of the real impact factors now that people can be watching for in their work is it picked up by people? And does it make its way into the next generation of guidelines? And so this notion of social determinants and helping people in the context of their daily lives is what I hope we are going to be seeing much more of as we get these evidence-based guidelines. And this is what will help the H in NIH become meaningful, and the return on the investment that all of us have and care about so much in research. So I look forward to further discussion. Thank you.
So this will be brief, but as you know, I can't do anything without having PowerPoint. And here we go. So it is a real honor to have Sir Michael with us. He has been, he doesn't know this, but he's been a hero of mine. And most of you in the audience, if you've ever heard me talk about health and public health, have seen me show this slide. And this, of course, is from the original Whitehall study. And I love to point out, and I still do it all the time, not only in lectures, but even in the book you heard me talk about that I recently published. This figure is in that book. And what I find astonishing about it, in somewhat different from the very wide-ranging scope of Michael's present interests, where there are so many variables changing, there are very few variables here. These are a pretty homogeneous group of individuals, and just to remind you, I call this, the Brits are good at social class. We do race, you do social class. So this is the highest social class, and I refer to them as the born to lead class. These are the professional and executive classes, that's us, that I would posit, though you might educate me otherwise, are probably better educated, in fact, than the born to lead class, because they are professionals. And then, of course, you got the clerical and so forth, and you have this extraordinary social gradient. And even when you correct for all those things that we think about correcting, smoking habits, obesity, what have you, you still have this social gradient. And I've told more than probably 10,000 people now in lectures like this that if I were to start my research career over again, this is what I would work on, because it is absolutely fascinating. It gets a little bit more confusing as you go wider around the world. He's touched on this. It's another area that you looked at. Again, patients surviving in Ontario, Canada, having had a myocardial infarction. They're all in the same healthcare system. It's single payer in Canada, and this is only one place in Canada. And again, you look at the income quintiles, and of course, the people with the highest income quintiles are having better survival outcomes than are those who are being taken care of in the lower income quintiles. Go explain that. This is something that we could have, because I have this slide, I just couldn't find it this morning. For New York City, you looked at health disparities in the early 1900s. Blacks in Harlem died at 3 times the rate as people living on the Upper West Side. And of course, I think Michael was referring to this in part, because he did mention, then moved on, because he thought he was coming back related to Kerala. So this is U.S. White male survival. This is Kerala, India. This is Bangladesh, and this is blacks in Harlem. There are lots of reasons for that being the case. Too many for me to go into. This data does come from his colleague Amartya Sen, who sits on a commission with me as well. There are lots of, here's one explanation, homicide rates, white males, black males, totally different from the rest of the population. And in fact, the mortality rates in the United States from assault are an astonishing 6 times the rate in any other OECD country. 6 times. And then, of course, you get how the healthcare system works. So here you have transplantation rates in the United States in people with renal failure. You look at the experience amongst black men and black women and black men versus white men and women. Everybody wants to have a transplant, but look at the differences in referral for transplants and the difference of those put on waiting lists. So it's a complicated series of issues. Haven't even gotten into the self-efficacy and the power phenomenons that Michael has brought great attention to, and there's all of this stuff going on. I should point out to you, you've come to the right institution, Michael, because you could have learned something 100 years ago that would have saved you a lot of work. William Henry Welch, our first dean, famously said, it's a well-known fact that there are no social, no industrial, and no economic problems which are not related to problems of health. I had the feeling that we had a speech that just before this that was sort of a combination of Jeff Sachs and Amartya Sen, and I mean that in the very best way. Michael, we're delighted that you're here and that you addressed this. Thank you.
I'd like to open it for questions or comments. I would ask that please use the microphone on one or another side.
Thank you very much. Is this working? Thank you very much. I've always heard in Disparities that there's a difference between closing the gap and perhaps, as the curves keep edging forward, keeping that gap but making sure that the lower one also is up to that level of health. So from the standpoint of health capital of a nation, of a global world, do you see a conflict between closing that gap and perhaps the danger of slowing down that rate of increase of general health? And is there a point beyond which, so at what point do we know that we have achieved the outcome, closing the gap?
It's an interesting question. Somebody will often say, aha, I know that the way you want to close the gap, reduce inequalities, is to make things worse for the best off, to retard their improvement. And some bright spark will often say that. I've said that there should be no conflict between improving health for everybody and getting the people who are not sharing the benefits that are leading to the improvement in the best off to share a greater to have a greater share of those benefits. I've been told by economists, Michael, you can't get away with that. There's a trade-off. There's always a trade-off. I hate economists. Heckman from Chicago, interestingly enough, says investment in early child development is a rare example of public policy where equity and efficiency come together, because investing in early child development will lead to closing the gap, and it's an efficient, from his economic viewpoint, an efficient way to do it. I mean, the logo, you probably didn't see this in passing, the logo we elaborated for the English Review actually shows the gradient, and it shows everybody getting better, but it shows those down the bottom getting better more rapidly. And that's why I say, regardless when people tell me you have to have trade-offs, we ought to be aiming for both.
And it's doable. Thank you.
Perhaps one other question?
Thank you so much for the talk. It was very interesting. I am interested in your opinion on how technology could, specifically access to the internet, might help us close the health disparity gap, or if you think there is a role for technology.
I don't know whether I disgraced myself, but I astonished myself. I was at a meeting in Brussels bioethics meeting in Europe, and I was talking about health inequalities in Europe and approaches to solving it. And somebody from the audience was not as polite as you've just been, got up and said, we're in the 21st century, and you've said nothing about information technology. Without that, it's all a bit abstract. And I was a bit surprised how heated I got. I was, by the end of it, I was thumping the table. I said, you know, if I could have taken you to Liverpool and see young children whose lives are blighted by the neglect they're having, and you think that's abstract, if I could take you to see people who are afraid to go out on the streets because it's unsafe, and you think that's abstract, you know, I thought, good heavens, where did all that come from? People were, as I walked out afterwards, they were touching me, and sort of, you know, and I wasn't quite sure whether they were trying to soothe me or just, you know, my God, at least they knew I cared. But you didn't ask it that way. I do think that these social conditions are of vital importance. That said, I think the mobile phone is empowering. The fact that my colleagues in India can talk to each other now. When I was first in India 35 years ago, it used to take 2 days to make a telephone call. Now people get on the mobile phone. I think the internet is empowering. Now, I don't think that's going to solve the problems of the favelas in Brazil, but I think it is one step in the right direction of empowerment. So I think technology does matter, and I think it is an aid, but we need to get the social conditions right, because we need to be very careful that, and it's a discussion I've had about education. My colleagues who've prepared evidence for us on education say that innovations in education increase inequalities in educational outcome. It's a bit shocking. And then a moment's thought is right. You bring some new technology into the classroom, and the middle class kids say, oh yeah, hang on, yeah, that's fun, let's have a go at that, and, you know, and they're off and away. And the kids from deprived backgrounds, a bit like those Indian children solving mazes who are told that you're disempowered, then they say, oh gosh, I can't touch this technology. So the kids from more privileged backgrounds are off and away, and the kids from more deprived backgrounds aren't in a position to take advantage of the new technology. So I think technology is potentially very important, but we need then to look at the distribution and how it is influenced by the social determinants.
I would like to continue the conversation, and we will be able to at the reception in Finestone. Please join us, and thank both Professor Marmot and Dean Hall.
Thank you very much. I enjoyed it very much.
Thank you.
My favorite paper here is